you all so much for joining us for this episode of RD Updates. I'm very excited to see all of you here with us. We're excited to be joining you from our homes today, and I just wanted to point that out because this is the first time that we're trying RD Updates from our homes, from our home internet connection, but luckily one of our hosts is in the School of Health Professions building, so if we happen to have any technology issues, he at least is in the School of Health Professions building. But we're really thankful that you're all here and that we're able to host these RD Update sessions through Zoom. Just a couple of housekeeping items before we get started. If you have any questions throughout the segment, please just type them into the chat box because I'll keep an eye on that and I can be asking Dr. Kitchin questions as we're going through the segment. And also for your CPEU certificates, please just drop your email into the chat box and I'll just send everyone the link that you need to fill out to get your CPEU certification. But I think that might be an easy way for us to do this. And with that, I think, again, we're ready to go ahead and get started. So I'm excited to welcome Dr. Beth Kitchin today as our expert in osteoporosis for today's segment. Beth is Assistant Professor in our Department of Nutrition Sciences at UAB, but Beth is also an osteoporosis patient educator. And she's been a patient educator for a number of years and leads a wonderful nutrition education class for osteoporosis patients. And Beth, I'll let you go ahead and continue to introduce yourself. Tell us a little bit more about what you do.
Thank you, Tara. Thank you all for being here. It's really nice to see everybody. I am the patient educator in the UAB Osteoporosis Clinic, and it's a little bit of an unusual place for a registered dietitian to be. And I give that credit to Dr. Sarah Morgan, who many of you know. She was in our department. She was my boss when I first came on back in December of 1996, so a very long time ago. And when I accepted the job, was very excited to be working for her. She said, well, one of the things you'll be doing is you're going to be my patient educator in the osteoporosis clinic. If any of you remember Nidra Wilson, I took her place. I always loved her. She was sort of my idol, so I was really excited to be sort of taken over that job when she retired. And so it was a really unusual place for a dietitian to be, you know, in bone health and metabolic bone disease. And I ended up just loving it. One of the things I really loved about it was that it's not weight loss. I had worked in weight loss programs. I was still doing some work in weight management programs. And some of you may be working in weight loss programs, and it's hard for people to lose weight. It's really challenging, can be very stressful for many people. And so I was kind of ready to be doing something different. And so I really enjoyed learning all about metabolic bone disease. And there was a whole aspect of medications involved, DEXA scans. So I got to learn a whole lot of new things. And that was really fun and exciting for me. And so I still work with Sarah over at the clinic, even though she's retired from nutrition sciences. She's still the director of our clinic. We're now working remotely, of course. And so we've just had a really good time working together. And she's a great champion for registered dietitians because she is one. She's a medical doctor and a registered dietitian. So she's always out there promoting our profession. And so it's just been a really neat experience for me. And if any of you ever get a chance to kind of spread your wings and get into an area that's a little bit outside of straight on nutrition, it can be really exciting.
That does sound so exciting and such a unique experience. I know when we decided to have this session, I was very excited for it myself, just to learn a little bit more about what your experiences are at the osteoporosis clinic. And just as you said, I think, so before I came to UAB, my experiences with outpatient nutrition counseling were all related to weight loss. That was probably 90% of what I did. So I can completely relate and think how that would be so fun to just branch out into something a little different than what we see in a lot of our outpatient settings, and something that's so important too, to be working with patients with their nutrition care for osteoporosis. I think that's incredibly important. So tell us a little bit about what are some of the challenges that you've faced with educating patients with osteoporosis?
Well, right now the challenge is it kind of goes back to what we talked about in our first Zoom RD updates, and that's, media messages, research that comes out. And so this is an area where you have your patients seeing the latest scary headline. And so that's what I'm going to focus on today, is how Dr. Morgan and I sort of navigate what people are seeing in the headlines. It's often from research. The research is out there. The research is real. But a lot of times, as we've talked about, it gets misinterpreted and exaggerated. And so what I'm going to focus on today is talking about some of those big issues. And a lot of times, Tara, it's the patient that I hear about the headline first. Sometimes I'm reading it, in the newspaper, but a lot of times it's the patient that says to me, Beth, I heard that calcium supplements are going to give me heart disease. And I'm like freaking out, and I'm going, looking for the headline. But then the next thing I do is I look for the study. And so I listen to what the patient is asking me, then I have to go and find the study, and then I've got to look at the study. Sometimes I can interpret it myself. Sometimes I've got to send it to one of my doctors and say, okay, this is what I think this study really says. What are your thoughts? And that's a great collaborative process to be able to talk to our doctors who are in patient care and also research. And then from there, I have to formulate the message to the patient, so it's taking that data and then saying, well, how do I message this so that the patient can understand and hopefully tamp down their fears of taking something like a supplement. I'm going to focus on nutrition, but boy, I'll tell you, the place that's even worse than the nutrition aspect of those messages is with medications. Any of you that work in areas where patients are on medications, that's where some really scary messages come in. We've got osteoporosis medications that, people misinterpret the data and say, oh, it's going to make my jaw rot. It's some really scary stuff, but we'll focus on nutrition, obviously, for this. So I'm going to share my screen and pull up a couple of slides. And of course, we'll go back and forth between this. And so one of the things I want to talk about is, first of all, calcium. Calcium is one of the biggest things that I counsel people on. And these are the guidelines. So right now, the guidelines for the patient population that I work with is generally going to be somewhere between 1,000 to 1,200 milligrams a day. A lot of times my doctors like us to go up to 1,500. If Dr. Morgan has a patient with celiac disease or who's had gastric bypass surgery, sometimes she wants them on 2,000 milligrams a day because of, poor absorption. So sometimes we actually go pretty high with that. Interestingly, the new daily value on the food label is 1,300 milligrams, which is something I'm very happy about, because before that happened, before they changed that, I had to really help people navigate the label because the percent daily value didn't really apply to them because it was for 1,000 milligrams and most of our patients needed to be on higher amounts. Now the daily value on the label is 1,300 milligrams, so that percentage works for them. So that made me very happy. I don't have to do quite as much work educating on the label and teaching them how to adjust that. So that's really nice. But this is one of the types of headlines that people see that we get phone calls. Sarah, Dr. Morgan will call me and say, oh my gosh, one of my patients said, I'm not going to take my calcium because I read this headline. It doesn't really help, so why should I bother taking it? So of course, what do? Well, we dive into the actual study and we have to try to figure out, what does the study really say? But these are the kinds of things that we see. I read the calcium doesn't help my bones. Why am I bothering taking it? And so what we do is we jump into the data. We may look at that particular study, but we also look at other studies because, as all of us know, there's no one study that's going to direct your recommendations. We look at the body of evidence. And so some of the things that some of these studies show is that calcium supplements don't reduce the risk of fracture. Now, this is where the messages are very nuanced. I'm a nutritionist, but in all honesty, calcium by itself is not a treatment for osteoporosis. And so I always start there with my patients saying, calcium is a support. And this is where it's really weird being in the osteoporosis clinic, it's not like being in diabetes or heart disease, where nutrition plays a huge role and can even help prevent the disease and maybe be an actual treatment. In osteoporosis, nutrition is more of a support. You're not going to reverse postmenopausal osteoporosis with calcium supplements. But we also know that the medications are not going to work as well without the calcium. And so this is one of the places that I start with patients. And it's like, well, when you see those headlines, we have to start at the beginning, which is we've never told people, take calcium and you won't break a bone. So we have to nuance those messages, which is not always easy. But if you look at this data, and this is from a meta-analysis that told people, don't bother with calcium, it's not going to reduce your fracture risk. But when you look at their meta-analysis and you look at the studies that they analyzed, you look at the studies and you can see the left there, I have high risk of bias. I have that circled. Those studies, what you see, I think there's my little box there. This is sort of the data that a lot of people drilled down into, where it was the studies that had a high risk of bias, and that some of them really leaned heavily on that there was either an increased risk of fracture or no benefit from taking calcium supplements. But overall, you can see down here, I don't know if you can see my pointer, but if you see here, the point estimate actually falls within where it actually would benefit with calcium. So a lower risk of fracture. This side is showing you where there's a lower risk of fracture. These are the point estimates. And then of course, this is the relative risk of 1. So this would be no significance right down here in the middle. But if you look at the better studies, they all kind of come down on the side that, yeah, there's a moderate increased benefit. Now, is this huge? Again, what I tell my patients, take supplements and you won't get fractures. No. But when you look at the body of the data, it actually does favor calcium supplements. This was the conclusion of that study, that, yeah, increasing calcium intake did produce increases in benefits in bone mass density, but unlikely to achieve a clinically significant reduction in fracture. And while that's probably true, the idea here is that we're not just doing calcium. Calcium works in synergy with exercise, with medication. So looking at it from just the perspective of a calcium supplement may not be the best option. Now, again, we look at the body of the research. This is another finding, another study here that showed that there was not a huge benefit of taking calcium supplements. But again, you have to look at the limitations of the study. And with this study, they did not look at baseline vitamin D, which is really essential. If you supplement with vitamin D, but people are not deficient, you're not going to see a big change because they are already getting enough vitamin D. And then there were some other weaknesses with this study as well. But then you look at some of the studies that we've already done or people have done in the past, where there does show a positive effect on reducing fracture risk of calcium supplement. And this was a 2008 pretty solid randomized controlled trial that showed, again, a modest reduction. But again, I always go back to tempering this with, we're not telling you that calcium's the end all be all. It is a support. Again, other studies that really support that calcium is beneficial for bone mineral density. This is supplementation looking at the effects of lumbar spine bone density. Now, we always have to take bone density and keep it in perspective. Bone density does not equal fracture risk necessarily. And the endpoint that we care the most about is, well, does it lower fracture risk? But bone mineral density is still important. And what we see is that when people supplement, you see, and this was a study done in Thailand, I believe. This was the Thai population that had a very low level of calcium. So again, you always have to remember, where are people starting from? calcium level is low, you actually do see benefits to the bone density with supplementation. With the spine data here, you actually see an increased risk. Placebo had, not an increased risk, I'm sorry, an increase in bone density, much greater than placebo. Femoral neck, which is the hip data, you see less loss. So there was not an increase in bone density, but much slower, less loss than placebo. And as we know, particularly in postmenopausal women, slowing down loss is good, because postmenopausal women, we're losing bone density pretty consistently. And so again, going back to this issue of this sort of simplistic view of calcium in, calcium out, I should say bone density out. And so I try to really get across to patients that it's just not this simple. It's more complicated than this. And this is where it gets tough, is explaining to people that osteoporosis is not just a calcium deficiency. It's not just an issue of calcium. You can be getting plenty of calcium, doing a great job with your calcium and your vitamin D, and still get osteoporosis.
Mm-hmm. That's so interesting. And I understand how that could be a struggle for you as a patient educator, because I think all patients in some way or another are looking for that magic elixir. Let me just take my calcium supplement and I never have to worry about developing osteoporosis or never have to worry about losing bone density. But like you said, that's just part of the picture. And it sounds like calcium is so important for especially patients that start at a deficit for really improving their calcium levels by taking a supplementation, or if they're already starting at a good baseline, it can prevent bone density loss. But how do you get patients to see the big picture with all of this?
Right, and that is the tough part, is then communicating this really complicated physiology to people is really tough. And you're right, people, who wouldn't just rather take a calcium supplement and not have to take a medication that could have scary side effects? Who wouldn't? I want to. I mean, I have osteopenia. I'm at an age now where I'm struggling with these decisions as well, so I really get it. And I know a lot about it, and it's a struggle. So one of the things that I do, Tara, is I use analogies to talk about that osteoporosis. I try not to use metabolic bone disease, but that's kind of what I'm getting at, is it's a metabolic bone disease, that what's changing is what's happening in your bones with the bone building cells and the cells that remove old bone and then replace them. And so I talk about this as your bone bank, and you've got withdrawals. Those, of course, as we know, would be the osteoclasts coming in and getting rid of the old bone. But then you've got deposits. And that's the osteoblasts coming in. I don't use osteoclast and osteoblast, but you guys know what I'm talking about here. And so I talk about how as we get older, our deposits start to go down, our withdrawals start to go up, and that is controlled by a lot of different things. Calcium helps, but it's not just a matter of pushing calcium into the bones, because we've got these bone cells doing these things that are affected by our lack of estrogen, aging, all these other things. And so I always start out my education class that I teach with a risk factor checklist. And this kind of goes back to health behavior theory, Tara, that you are learning a lot about, right? So increasing susceptibility to an accurate level, not trying to scare people, but trying to show people that, yeah, you actually might be susceptible even though you don't think you are. And so I use this checklist as a way of showing, look at where calcium is. And this upper part, I always tell them, these are the biggies. These are the biggest risk factors. And what do they all have in common? We don't have control over them. Osteoporosis is something that we have less control over than we probably like to believe. We have some control with these health behaviors down here, but these things up here that we don't have control over play a big role. And so I try to get it across to them, look at and check off. Go and I'll see people when I've been in the classroom. I'm not in the classroom now, but taking their pen and going, oh, wow, I have a lot of check marks on here. And the more check marks you have, the more likely you are to have osteoporosis.
Wow, I think that's such a brilliant way of starting your patient education classes. It's great for not only you as the educator to see what is the status of the group that I'm working with right now. So you can quickly assess too if you have a lot of high risk patients.
Exactly. Yeah.
But for them too, to really see, okay, if you check all these boxes and you're at high risk and they can see it concretely right in front of them. I mean, even just I'm looking at this, I'm thinking, I have a few members of my family I'm going to call after we get
Yeah,
see what they're doing.
absolutely. Yeah, good. Do that. Good. But you know, the thing too, Tara, is that and I will tell you guys, people go, oh, this is great, Beth, that you do this. Even after I do this with people and then I counsel them afterwards, I still have people that this doesn't internalize. And that's why repetition of messages is so important. Because I'll still have people who come to me after doing the class, after filling out this checklist, and they'll say, but I drink milk, I get calcium, I just don't understand why I have osteoporosis. I'm like, well, let's look at your checklist. And remember what we talked about? So don't feel bad. I mean, I do feel bad when that happens, but it's like our messages don't always go through that first time. And that's where repetition of messages, you know, is really important.
So important. And I can see how it's challenging too when we have conflicting news headlines too. So you might be saying one thing, or Dr. Morgan might be saying a similar message to what you're saying, and you're trying to do your best with educating your patients. But then we all go home and watch the news at the end of the day, and we see those big headlines pop up. So I can see how that can be a challenge for you as an educator. Tell us a little bit about the headlines that we see about calcium and heart disease. That's something I'm interested in.
Yeah, this has died down a little bit. I'm not getting quite as many questions about this as I used to, but for a while there, in clinic, this was a biggie because, and I still do get questions, just not quite as many, but one of the things I always have to keep in mind is my patients come in, and many of you experience this too with your area of expertise. And for me, most of them don't just have osteoporosis. They have other things going on, and we have to really be mindful of that their bones are not their only concern. They may be going through cancer treatment, or had breast cancer in the past, or other types of cancers. They may have heart disease, diabetes, a lot of other comorbidities. And so we have to be very mindful of that. But this was one of the big headlines that we still deal with calcium supplements may damage the heart. Now think about yourself as a patient, and Dr. Morgan and I have just told you to take these calcium supplements, and then you're like, but they might damage my heart. That's a really scary thing. And you see, this actually is not a study headline. This was a headline from Johns Hopkins, a pretty reliable source, talking about the study. And so this is where we really need to be accurate in the way we report on these studies. And everybody knows that's my big passion, is let's be really careful about this. So there have been a couple of studies that came out. There was this big, the Heidelberg study, the EPIC Heidelberg study out of Europe. And then the other thing that you hear people talking about is the calcium, the coronary calcium artery score, right? People hear that. And that's a new, diagnostic thing that's coming out that we talk about with heart disease. Well, what do you think people think when they hear coronary calcium? There's calcium in my arteries. Of course, they're going to think, oh my gosh, my supplements are doing that, when that's not really quite how it works physiologically. But you can see how people would make that link, right? It would make sense, right? So we have to look at these studies. And as it turns out, just long story short on this, I'll show you some of the data, but I don't want to bog you down with too much data. But these studies got really overblown and very misrepresented. So this is, again, here's the patient question is, you told me to take those calcium supplements, but it causes heart disease. Why should I be doing this? Do one thing and then cause another. Well, this is the a meta-analysis that was done looking at calcium and relative risk of various aspects of heart disease. So we've got heart attack up there, MI, relative risk of stroke, a combination of MI, stroke, sudden death, and then relative risk of death. And so you see these relative risks, and these are all observational studies most of the time. Some of them have been randomized controlled trials, but they're randomized controlled trials where heart disease and calcium supplementation was not the outcome, because you're probably not going to randomize people to do that, right? So it's probably where that was a post hoc kind of analysis. But look at where these come down to a slight increased risk. But when you look at all of these, look at these confidence intervals, they all cross 1. Okay, or very close to crossing 1. And what that means is there's a good chance that there's nothing there. And so that gets sort of lost a lot of times in the headlines. And for that particular study, the Heidelberg study, there were a lot of some issues with that, you know, and so these are some of those, this is from that particular study, the one that we just looked at. But the problem is there's conflicting data. You can find one study that shows, yes, there's a slight increased risk. Well, here's another study from 2011 that showed no increased overall risk. So you could see the hazard ratios falling on, you know, again, nothing significant. Most of them cross 1 except this one right here. And so that one shows, you know, a decreased risk actually, but all the others show non-significant associations with this. And so when we really look at the data, we really don't see this increased risk. Now, we do recommend to our patients, let's not overdo supplementation, you know, because more is not better. Don't just pour more calcium into your body. That's not going to be good for you. This is another big meta-analysis. That's actually not a meta-analysis. This is the big biobank cohort from the UK. And this actually showed no association. So again, you know, pick your study, right? And you know, look at the limitations. But this was a study that looked at ischemic heart disease. The two graphs that you see up at the top, those are incident, and then the two down there at the bottom, those are death from myocardial infarction and ischemic heart disease. And so you see, again, no significant association, some actually a lower risk of risk with supplementation, but they all cross 1, none are really statistically significant. So probably what this is falling down on the side of is, you know, no risk one way or the other, most likely. This is the EPIC Heidelberg study, and these are kind of all the issues with that one that was really hitting the headlines. You know, it was all observational data, cannot show cause and effect. There was a small number of events, of cardiovascular events, and as you guys know in data, when there's not a lot of events, it really weakens your data. And you can see some other issues there. And look at the second to the last bullet point. The messages that did not make the headlines, right? It was the scary message that met the headlines, but they did not have a risk of increased stroke or overall CVD mortality. That one was no one had a headline on that. The headline was, you know, increased risk of the other stuff. So again, these are the kinds of things that I can tell my patients. I won't go into this data is interesting. But I won't dive into this too deeply, but this is the arterial calcium data that everybody gets real hooked on. And when you look at the different quintiles, it's weird because you see the relative risk with supplementation going up, but then it starts to come back down with the higher quintiles. And so when you actually dive into this and dig down into the data, you're like, nah, it doesn't really show what you're saying it shows. And so this is where I've talked about this a lot, where we've got to get comfortable diving into the data. But then also for me, I've got these fabulous doctors that when I look at the data, I can email them and say, okay, you guys, this is how I'm seeing this. Am I right? Am I wrong? Nuances. How should I be communicating this to the patients? And so it's nice to have that team of these, well-known doctors and researchers. So, and I'm not going to go into that. This is, we'll skip that cheese data that I was going to talk about. But anyway, so this is what we've got to be looking at. And it's good to always have those colleagues that you can say, all right, check me on this.
Yeah, no, that is such an important thing to have, having that interdisciplinary team that you all can look at the data together and see what is the study really saying, and making sure that you're all on the same page with your patient education. And everyone's trained in different ways and learns different expertise and skills, especially when it comes to looking at studies. Because you make a great point too about how some studies, they'll have a headline for the study that says one thing, but when you really get into the nitty gritty of the numbers, it's like, is this headline picked just because it sounds better? Or
right. And then sometimes they focus on one aspect of the study, like we said, without looking at the other things that were not as scary. If it bleeds, it leads, right? So.
Right, exactly. Yeah. So it's good that you can have that interdisciplinary team where you all can look through these things together. But then I know we still have the patients and giving education to your patients. So what do you recommend to your patients when they start to have concerns over these supplements? If they're seeing things like, I'm going to get heart disease because of taking a calcium supplement. And I know we'll see this in other areas of practice too. As soon as you said when they hear calcium with their heart, they assume it's the calcium supplement they're taking, immediately made me think of people being afraid of fat, because they worry, I'm going to increase my body fat if I eat fat. And so I think we see that so often with dietetics. But how do you handle that with your patients for their supplements, or even if they become scared of eating dairy food?
Sure. Yeah. And that's, that's important, because we talked about the data, but then what about the message to the patient, right? And that's, it's complicated physiology, it's complicated statistics. How do we message this? And so, I always say to the patients, well, those studies, the data was not very strong. The type of study that it was, it's not very strong. As long as you're keeping your supplementation reasonable and not overdoing it, you're going to be pretty safe. And then I always fall back on my doctors and say, I've asked our doctors about this and said, hey, what do you guys think? And they sort of agree that this is not something that we need to be too worried about. But what I always like to do is, and a lot of times that is comforting to them. But sometimes I'll have a patient that says, Beth, I get that, but I'd really like to not take supplements. But what can I do for my diet? And luckily, we can fall back on things like the DASH diet that has dairy in it, that is just an overall healthy eating pattern that's good for your heart. So it's like you can tell patients, here's an eating pattern that's heart healthy and bone healthy. And so a lot of times people get really excited about that, and it's a good message and it's an accurate message. And so that's what I like to talk about. And one of the things that I think is interesting about some of the data on DASH, first of all, we all know that DASH includes some low-fat dairy products. And I think we all feel more comfortable now with going with higher fat dairy products. The data really kind of shows that fat from dairy is probably not harmful to the heart. It's probably fairly neutral. But this is, of course, the data on blood pressure that we're all familiar with, where the DASH diet is effective in lowering blood pressure, and the data is really solid on that. But this is some interesting data looking at what we call bone turnover markers. And we've got these markers that we look that tell us what's happening in people's bones. One is OC, which is osteocalcin, and one is CTX. And the OC, when you see that going up, that's a marker of bone building. CTX is a marker of bone resorption, so bone loss. So we like to see levels of CTX not too going in the wrong direction, and we want to see levels of OC going up. And what you see from this data is with the DASH diet, you see kind of exactly, what you want to see with CTX and with OC. You see the osteocalcin, a slight increase, and you see less increases with the CTX. Now, we have to keep bone markers in perspective. Bone markers don't necessarily mean better bone density. They don't necessarily mean lower fracture risk. They are an intermediate marker. But again, I can tell my patients this. I can say, the DASH diet even has, might even have some, good effects on your bone markers. That's not the end all be all, but we feel pretty good about the DASH diet. It might actually be of some benefit to your bones. And that's a combination of those high fruits and vegetables changing the pH, possibly along with the calcium and all those great things. So that's, again, a good message to give to the patients.
Mm-hmm. It absolutely is. I know the DASH diet's one that I always feel comfortable with. So I'm glad to hear that when it comes to making recommendations for patients that are at higher risk of bone density loss or osteoporosis, that the DASH diet is a good recommendation to give them in addition to calcium supplementation, or as an alternative if patients for some reason or another don't want to take a supplement.
Right.
I love these little images you have on these slides, because it's just giving me flashbacks to when I was doing nutrition counseling myself, because I have gotten.
And they look at you like that. You're telling me to drink milk, but I hear it's, and you had asked about that, with dairy foods, right?
Yes, I think I've gotten this exact quote 20 times at least, and with that look too of, I don't know what you're saying about milk, because I've heard it's really bad for me, but right. What do you say to patients about that?
And again, I always honor patient autonomy. If somebody says to me, I'm not going to drink milk, and whatever their reasons, I do like to correct misinformation though, in a gentle way, because you don't want to be offensive to the patient. But I do feel like getting accurate information is out there. But I always say, but even with this information, if you just don't want to drink milk, that's fine. We can do this another way. It is always up to you how you want to tackle your calcium. You don't have to drink milk. But I do have patients who love milk. They want to drink milk. But then they have people telling them that it's bad. And so, they are really open to getting accurate information. And so we really want to be able to provide that for them. And this is a headline. Oh my gosh, when I saw this, that came out from the Physicians Committee for Responsible Medicine. And they have a very strong message of a vegan diet. That's where they're coming from. And there's nothing wrong with that. But in trying to sway people, sometimes they put out information that's exaggerated, that's overblown, that's not quite accurate. And this was a headline that came out based on a study that milk is going to make you die, basically. Drinking 3 or more glasses of milk increased mortality by 93%. That is a very scary message. Mm-hmm. And so, of course, what do? We go and we look at the actual study, and it turned out to be, same old story, right? Different, same song, different tune, or whatever they say, where this was a big observational study, no causation, even though they used causal language in that messaging. And look at what look at the actual results. Even some of the researchers who did the study came out and said, well, that's not actually what we said. They were looking at this research that came out. They were not, the PCRM doctors were not the researchers, but look at the conclusion. The results should be interpreted cautiously given the observational design of our study. This is not a study that you make recommendations off of. And it was sort of that typical, that we've talked about in the past, the weak relative risk from an observational study that often turns out to be nothing, So is this really something that we're going to base that off of? And you show me your study, I'll show you a different study that shows something different. Here we go, right? So here's another study that, shows the complete opposite, and so that's something. Let me go back to. So anyway, so this one shows, that there was risk. Some studies, and I think it was this one, actually show with some dairy foods, the fermented dairy foods like yogurt and cheeses, a slightly lower risk. I hesitate to go telling people that you will actually lower your risk, again, because it's observational, no causation. So I'm very careful not to go telling people, well, it might actually lower your risk. I feel like with the data we have now, and again, that's given the data we have now, I feel like dairy, the risk of all-cause mortality, cardiovascular disease, I tell people it's kind of neutral. Mm-hmm. That's kind of my take on that. So
that's good. That's so helpful to know. And as we're having this conversation, it's reminding me of our last segment, as you had mentioned, or 2 segments ago, when we were talking about media messages and how important it is to be able to understand studies. And we were talking about how we might do an individual separate segment just for that, just to look at really good study review skills. So I'm going to take this opportunity to ask our audience, if you are interested in something like that, so you feel like you're comfortable looking at a research study and telling, this is observational, so this is what I should take from this study, or this is a randomized control trial, this is what I should take to the study, go ahead and comment in the chat box just so I can get an idea of interest, because this is something that we had talked about after our Media Savvy RD segment that we had just a couple months ago. And I'll put the link for that in the chat too. So if you haven't checked out our recorded sessions, you can go back and see that one. But just if you are interested in learning more about how to really interpret the data that we see from research studies, please just leave a comment, because we are interested in hosting a session like that if there is interest from the audience.
Yeah, Tara, thank you so much for doing that. Tara and I have been talking about this, as she said, and we have a couple of people, one in particular that we're trying to get in to do a session with us on that. One of my favorite professors from when I was in PhD world. So.
Yes, and he's an epidemiologist.
Yeah.
Right? So, yes, that would be, I would love to host him for one of these segments. I think that would be really helpful. And I know I felt remotely comfortable with studies after my undergraduate program. After my master's, I definitely felt more comfortable because I did research, but it wasn't until now I'm in a PhD program, I'm like, all right, I know how to look at a study. So
yeah,
if you don't feel comfortable, there's nothing wrong with not feeling comfortable. It takes a lot of looking at the literature, I think, to get used to what exactly is this telling me. So just a quick note on that.
We're excited about that. So let us, I'm so glad you said that, Tara. Thank you.
Yeah, absolutely. And here we have another one of these awesome graphics.
Sorry. And what's so funny about this, Tara, is I actually got, this slide I use a lot. I actually got this question just last week, emailed to me from a patient. Yeah.
Oh, that's so funny. Because I know I've gotten this one before too. I definitely have gotten this. So it's funny, again, you're giving me flashbacks to when I was working in outpatient care. But these are good flashbacks. So tell us a little about this.
Yeah, so people get their labs back, right? You get your laboratory, your labs back. And of course, vitamin D is reflective of your intake. We can look at your vitamin D and say, if it's low, we need to you need to get more. If it's high, we may need to back you down. If it's in the middle, keep doing what you're doing. But calcium doesn't show that. And most of you probably remember why from your physiology. But a patient's not going to know that. A patient's going to go, I've even had patients who had physiological backgrounds, were healthcare professionals, and asked this question. So don't assume that just because someone is a scientist that they remember their physiology. So, a lot of people say, but my calcium says it's normal. I guess I must be getting the right amount. Why am I even worried about my dietary intake or my supplement intake? And of course, you guys remember this, right? Calcitonin and osteocalcin that, what I don't show this to patients, I promise you, but this is what it comes from, right? And we all know that calcium does more than just keep our bones strong. We need to have that blood level of calcium stay in that very tight range because it's helping with sending nerve messages, muscle contractions, blood clotting. And so basically what I tell patients is I say, your blood level of calcium has to be kept in this really tight range, or some really bad things could happen to you. Your body's not going to rely on you. getting the right amount of calcium from your diet. The stakes are too high for that. What if you missed it and you're not getting your calcium? You know, and so the body uses your bones as sort of a storage or a reservoir of calcium. If that blood calcium starts to get too low, guess where your body's going to go to boost that blood level of calcium back up? And most patients will go, oh, my bones. Like that. So basically, I tell them that your blood calcium being in the right range basically just tells us that your body's doing a good job of controlling that blood level. It doesn't actually mean that you're getting the right amount of calcium. The only way we can tell that in a low-tech way is to ask you how much you are getting. And in fact, with our patients, a high blood level of calcium tells us that they're actually probably could be having low bone density and osteoporosis because of potentially hyperparathyroidism, either primary or secondary, that could be caused by low vitamin D. So when we see a high blood level of calcium, that tells us that the body for some reason may be pulling too much calcium out of the bones, and that's actually a risk factor for osteoporosis. So this is where, you know, some, again, messaging, and over the years, you know, you kind of get the hang of how do I explain this to patients, and just, you know, explaining that blood level got to stay. And the body's going to do what it needs to do to keep it there, regardless of whether you're getting enough calcium. That's a very common question. And you can see why, right? I mean, wouldn't you, if you didn't know, hey, my calcium's normal, what am I worried about?
Right. Well, I think of it like when you're driving your car and you look at the fuel tank dial and you see, oh, I have enough gas. You don't stop to fill up your tank unless it's a really inexpensive price. I will sometimes do that.
Yeah.
But you don't stop to fill up your tank if you have 3/4 of a tank, right? It doesn't make sense. I think we just naturally are taught to interpret our things like blood values that way too, because we're used to looking at it as I fall within those ranges, so I don't have to worry about anything. But that goes back to the patient messaging that you shared, the education packet that you give them and the risk factors on the front. Things like that are so important too, just to make sure patients can see, even if you get your blood drawn and you see that your lab values look like they're normal, there's still all these other things that can be going on. And plus, if you're checking all these boxes, you could be at higher risk. So they might want to take a supplement just to be preventative.
Right, exactly. And that message of, you know, you're getting the right amount of calcium, changing that is not going to change your bone density, but if you stopped taking it, you could start to see losses. And that's, you know, that message of maintenance is not the most exciting message, right? You know, people are like, what can I change to improve? There may not be a lot because you're already doing a lot of great things, you know.
Yeah, absolutely. So along those lines, and to kind of wrap us up, and I'll just give another comment to the crowd that if you have any questions, go ahead and type them in the chat box now, because we'll make sure that we address them before we finish our segment today. But what are the recommendations that osteoporosis experts go with now?
Let me go back here. So just some summary points. You know, in our clinic, you know, the reason I'm there so the doctors can say, we want you to talk to Beth, because she's going to talk with you about getting the right amount of calcium and vitamin D. And so what I work with patients is, of course, I take the doctor's recommendations. Most of the time, it's, you know, I want this patient on 1,200 to 1,500 milligrams of calcium. And it's going to vary. You know, if they have a risk of kidney stones, we want them to go mostly with dietary calcium from dairy, because supplemental calcium, there's a slight increased risk of kidney stones. So we want to keep that to a minimum. So all of this is tempered by what else is going on in the patient. But if they don't have anything like that going on, they can get their calcium from foods, supplements, or a combination of the two. Sometimes people have issues with constipation from supplements. So those are some things that I talk with patients about how to work on that. So those are some of the issues that we have. But I always assess, I think I had there we go. The most important thing is getting a feel for where they are now with their calcium, because we don't want them to overdo it. So if they're getting some from their diet, I basically say, you know, here's what you're getting from your diet. Where do you want to go from here? We need to increase your calcium. Do you want to take supplements? Do you want to change your food intake? How do you want to do this? And so that's basically how I handle that, unless there's a specific recommendation from the doctor. And then vitamin D is actually pretty easy because we recommend supplements for vitamin D because it's hard to make it from the sun for most of our population. And the food sources, there really aren't that many. And then we can measure it. You know, I always look at their vitamin D levels and base my recommendations on where are their vitamin D levels. Do they need to increase it? Are they good? Sometimes we have people who have been overzealous with their vitamin D and they're actually in a range that's too high. And so we back them down and say, no more supplements for you for a couple of months until we get you down to normal. Then we're going to put you on the recommended amount. So
and I definitely think vitamin D is one of those that we see in the headlines a lot too, and a lot of recommendations that aren't really based in good science or good merit. So I can see a lot of people possibly just taking a supplement without necessarily needing to.
Right. And this is a big message that I'll leave you with, that I leave with my patients with supplementation in general, is more is not better. You know, and that's such a, you guys know this as nutritionists, you know, people want to get more, even you can even overdose on water and get hyponatremic, right? So, you know, we always have to get this message across that it's the Goldilocks spot with nutrition where you want to be. And too much of us, you know, people have this idea, well, if I get too much calcium or vitamin D, I'll just pee it out. And it's like, nah, you gotta stay in that moderate recommended range.
Very good. And Beth, we have a question from the audience, so I'm going to go ahead and ask you a question.
I will go ahead and take my slides away then, so we can be face to face.
And I will say, while you're doing that, I love the idea of the Goldilocks range. I think that's so funny.
Yeah. Oh, and before we leave, I just want to show you really quickly. This is what we use. This is what the form that I made that I use for my patient recommendations. So I, you know, write down what they're getting and their multivitamin if they take one, supplement. So this is my little handout that I use. And then I even have this like schedule for them because, you know, you're supposed to spread calcium out throughout the day. So this is what I use, just in case you're wondering. So that's what I like to do.
Oh, that's wonderful. So let me get to our audience question. So the question is stature or low body weight or even smaller size still thought of as a risk for osteoporosis? And this guest has said that they've run into some size bias issues with bone health risks. So larger bodies not being at risk versus smaller bodies or low body weight being at risk. So how can you use sensitive weight language too when you're talking to people if there is a size difference?
Yeah, that's a wonderful question. And yes, low body weight is still a risk factor. Being heavier, it's not as though being heavier gives you extra protection though. So if somebody, I usually, and this is one of the things I like about working in osteoporosis, I don't have to focus on weight loss. And so I kind of actually like that aspect of it. But you're right, being weight sensitive, and I think what you mean, and please clarify in the chat box, is people sensitive about being low body weight. That was we had a cat issue here, sorry. But yes, and so gaining weight for people that are truly low body weight is a sensitive issue. And they may have some residual eating disorder issues, a present eating disorder, and that can be very sensitive. And so, again, I take my cues from my doctors, and a lot of times I've had them in class first where I can talk in general about, you know, low body weight is a risk. And the way I usually say it is I say, low body weight is a risk. Now, that doesn't mean we're going to tell you have to gain weight, but what it means is that being on the lighter side is a risk. It doesn't mean that you are unhealthy, though. If you're in a healthy BMI range, we don't want you to gain weight and then put you at risk for other diseases. If you are carrying extra weight and you want to lose weight, you know, you can let us know that and we can make recommendations, but we don't want you to have extreme weight loss as well. But yes, so low body weight is still an issue and it is a sensitive one. And you're right, we have to be very careful about that. I start with just saying, if I'm counseling somebody and they truly are below I mean, they are too thin. They're not eating enough, and there are some true issues there. I always ask permission. I say, you know, I see that your body weight is low, and the doctor's concerned about that. I always like to say, your doctor has told me they're concerned about that low body weight because it is bad for your bones. Can we talk about that? Is that okay to have a discussion about that? Because if they say no, I have to honor that. I have to honor that and document that I asked the patient and that I did raise the issue. A lot of times it's not an eating disorder issue. It can be celiac disease. It can be age-related, taste changes. It can be depression. It can be all kinds of things. And most of the time when I ask permission to discuss it, they usually say, yes. I had a patient last week that I talked to. Her body weight is really low. She wants to gain weight. I said, you know, can I talk with you about this? And she said, I want to gain weight. My body weight is low because I have IBS. I have these other things going on, and I'd like to get up, you know, over 105 pounds, you know. So, so anyway, my screen just switched back. Did it do that for you guys? I don't know what happened there. So anyway, that's a very good question. It's a very good question.
Well, I just got a reply too that was a very helpful response to that question. So thank you.
Good.
Sorry, I'm just reading our chats as they're coming in to make sure I'm not.
Again, it's always appropriate to. I always ask permission of the patient. I think that's really important because these issues are sensitive, and I've had patients that had sort of these, sort of what I call residual eating disorders from the past, and they're okay now, but they still struggle. It never has really gone completely away. They're better, but not completely better. Now, a lot of us, and I fall into this category, I'm low body weight, but I'm in a healthy BMI range. I mean, I think my BMI is like, 20 or 21. It puts me at risk for osteoporosis, but I'm not restricting my energy intake. And so I would be an example of somebody that you would say to, you're healthy, but just know that this is a risk factor. It puts you at risk.
Yeah. I think that's such an appropriate way of bringing it up because it is important to ask for permission for topics that are a little more sensitive, but then also as a clinician, we have an obligation to bring up these topics to give patients the education if they're receptive to hearing it. But things like this, they can be very sensitive topics. I think that's such an appropriate way of addressing it is asking permission.
And I actually ask permission even for things that we wouldn't consider sensitive.
Yeah.
Your doctor asked me to talk with you about getting more calcium in your diet. Is that okay with you? Do you want to talk about that? Because it just makes the person feel like you are honoring, it's important to honor autonomy.
I think that's wonderful. And two, no one likes just being like people to just bash information at them. It's like if someone came into your house, like if my mother came into my house, was like, I really don't like the way that you're organizing this. I'd immediately
Tara, your kitchen is a mess. What is wrong with you?
Which it's not. I'm a little more
I believe that.
Clean side.
Quick story before we close. My mom, I was home one time and she asked me to cut up some strawberries and she said, oh, it doesn't matter how you cut them up. And I'm cutting them up and I see her looking at me outside. And all of a sudden she goes, let me show you how I do it.
Right.
And I was like,
Right. And it's one thing to take it from a family member or a loved one, but to take it from someone you're just meeting for the first time who then is trying to tell you, you really got to fix this about your diet. It can come off as a little abrasive. So I think that's such a wonderful way. And that's a great tip to leave our audience with it. It's good just to ask for permission. Is it okay if I give you some education about this? And especially with those sensitive topics. And I'm so glad actually that this came up because it's a great opportunity to let our audience know what our next segment is going to be.
Yes. So excited about this, you guys.
Yes. Our next segment, we're going to be talking about eating disorders. And we have a registered dietitian who works in eating disorders and the therapist that she works with who will both be on the segment. This is going to be on Monday, September 28th at 11 a.m. So if you are more interested in learning about eating disorders and nutrition therapy for eating disorders and even tips for you if you're not working in that area of practice, but maybe you notice signs and want to know about best methods of helping your patients or referrals, please join us for that segment. Again, it's Monday, September 28th at 11, and I will send out a flyer about that. And if you could, please type your email into the chat box if you haven't yet, because that's the email I'll send your certificate for attending today's segment to, so everyone can get one continuing education unit for attending today. And I don't see any other questions, so if you don't have any other questions, we'll hang on the line for a minute, but if you don't, you're welcome to hop off. I just want to thank Dr. Kitchin for teaching us so much today. It's so funny, I actually caught myself writing notes because I really do want to talk to some of my family members. I've been jotting notes.
And we have a virtual classroom now that Kevin Storr helped me set up. Go to uabtoneyurbones.org, uab.edu/toneyurbones.
Okay.
Virtual classroom there that we set up because of, I can't teach in the clinic during the pandemic. You know, everybody's welcome to go look at those. So we welcome.
That's wonderful.
And Kevin was instrumental in getting those up on the website and making the website look good. So thanks, Kevin.
Yes, thank you, Kevin. And thank you, Kevin, for always being so helpful with these RD updates segments. We don't shout you out enough, but Kevin is our wonderful help from the School of Health Professions, and we would not be able to do these segments without him. So thank you for joining us today, too.
Thanks, everyone. This was really fun for me. I appreciate it.
Yes, thank you all. I look forward to connecting you all through email. I'll send you your certificates later on today. Thank you.